Welcome to Emergency Insights, the podcast where we delve into critical medical conditions every healthcare provider should know. And today we're tackling a rare but life-threatening condition, toxic shock syndrome, or TSS. TSS is caused by bacterial toxins, primarily from Staphylococcus aureus and Streptococcus pyogenes. These bacteria release exotoxins, superantigens, that trigger an overwhelming immune response. The result? A cytokine storm leading to systemic inflammation, shock, and multi-organ dysfunction. The most infamous toxin here is toxic shock syndrome toxin 1, TSST1, produced by Staphylococcus aureus. Historically, TSS was synonymous with tampon use, especially the superabsorbent varieties from the 1980s. These tampons created an ideal environment for bacterial growth and toxin production. But thanks to changes in design and awareness, menstrual TSS cases have dropped significantly. Today, less than half of TSS cases are linked to tampons. The syndrome can affect anyone, men, children, postmenopausal women, through sources like nasal packing, surgical wounds, burns, or even postpartum infections. Clinically, TSS hits hard and fast. Patients present with high fever, think 38.9 degrees Celsius or higher, hypotension, and a diffuse erythroderma rash resembling a painless sunburn. This rash often involves the palms and soles, followed by full-thickness skin peeling 1 to 2 weeks later. Other symptoms include confusion, headache, myalgias, nausea, vomiting, and multi-organ dysfunction. Streptococcal TSS is particularly deadly, with mortality rates of 20 to 60% compared to Staphylococcal TSS at 3 to 5% with treatment.
Diagnosis hinges on the CDC's clinical criteria: fever, hypotension, the classic rash, desquamation, multi-organ involvement, and ruling out other causes. Cultures may identify the culprit bacteria, but remember, bacteremia is often absent in Staphylococcal TSS. Treatment is a race against time. First, remove the source, whether it's a tampon, nasal packing, or a catheter. Aggressive fluid resuscitation is critical to combat hypotension and maintain organ perfusion. Empiric antibiotics should cover Staphylococcus aureus, including MRSA. Think nafcillin or dicloxacillin, with vancomycin for MRSA coverage. Clindamycin is a valuable addition. It shuts down toxin production. For severe cases, IVIG and corticosteroids may help neutralize toxins and modulate the immune response. And don't forget surgical intervention for abscess drainage or debridement, especially in Streptococcal TSS. In epidemiologically, TSS is rare. 0.3 to 0.5 cases per 100,000 for Staphylococcal TSS in the U.S., with Streptococcal TSS slightly more common. But it's a global concern, particularly in developing nations. Risk factors include tampon use, foreign bodies, recent surgery, skin wounds, and immunocompromised states. In summary, TSS is a toxin-mediated emergency with high stakes. Early recognition, source control, and aggressive treatment are key to saving lives. Stay vigilant, and remember, while rare, TSS can strike anyone, anywhere. That's all for today's Emergency Insights. I'm James Carter. Until next time, stay sharp and stay prepared.